we'll get started here again. Becca's decided to join us again, and I think Madison Smith is back as well. So that means we can start talking. We're going to shift gears a little bit, talk about illicit drug use. It's something that we see quite a bit. This talks about disclosures and mumbo jumbo. So by the end of this session, we'll be able to describe some trends in the United States. We'll look at 3 different categories of illicit drugs. We'll identify at least one effect of giving a drug we'll have on some kind of user, and then we'll explain at least one treatment with an illicit substance. We're going to go over several. I will forewarn you that this is a relatively new lecture for me, and so if I seem to fumble a little bit, it's because I haven't given this one quite as many. There's some statistics on illicit drug use. Almost 12% of individuals in the U.S. Have used some kind of illicit substance in the past month, which that's a pretty big number. About 5.3 million people in the U.S. have used cocaine in the past month, which is a huge number. And then about almost 3 million people, well, 2.5 million people have used methamphetamine in the past month. I will tell you that if you look at look at the graph on the left side, as many people know with statistics, they run a little behind the times. I mean, this is about 5-year-old data, so I would anticipate that those numbers have probably gone up. But we can definitely see since just in the last 20 years ish that those numbers are climbing, both male and female, which is pretty staggering. If you look at look at this graph, they're continuing to go up. I don't know if your eyes are good enough to see, but the one that really kind of goes up astronomically there towards the right is, I believe it's the antidepressants. Their antidepressants in general are one of, if not the highest prescribed class of medication in the United States. But, huh? Yeah. Is it synthetic opiates? Oh, okay. So my apparent color blindness isn't working from back here. There's 3 different shades of blue. Thank you for keeping me honest in the room. I've been up most of the night, so my eyes are a little blurry. Depressants are very high, and they are the highest prescribed drugs. I should probably look at my notes too. You did start with saying I did start with that. But the antidepressants are high. They're abused as well. But with the synthetic opioids, primarily fentanyl, which we're going to talk a lot about fentanyl here later, you can just see the curve just astronomically go up. Thank you, Mr. Prosser, for keeping me honest. When you drive a purple car, you got to know what blues are blues. This is true. I don't maintain my composure. This is just a graph showing you that the DEA has classified different schedules of drugs. When you look at Schedule 1, they're I mean, some pretty gnarly stuff. That's Schedule 1 drugs for heroin, marijuana, LSD, ecstasy, mushrooms, or bath salts, stuff you can get from your local drug dealer. You look at Schedule 2, you got some stuff from a drug dealer and cocaine, methamphetamine. But then you start getting into prescription drugs like Adderall, oxycodone, Ritalin, Vicodin, fentanyl. Schedule 3s would be like your ketamine, your Genraps getting anabolic steroids, the testosterone, Tylenol with codeine. Schedule 4s, we're going to see a lot of those on the street, and the Xanaxes and the Valiums and the Ambiens. Darvocet's been pulled off the market in most areas. Klonopin's another one that's pretty prevalent. And then you got the Schedule 5s, which would be like over-the-counter cough syrups like Robitussin. Lomotil is on there as well. Lyrica, and then the last one, I really couldn't tell you what that is. this drug schedule is not based on how dangerous a substance is. It's just a DEA classification of it. When we start looking at additional drugs, there are different categories, some broad categories: the stimulants, the depressants, hallucinogens, and antipsychotics. We're going to talk about each one of those categories here. There's a lot of overlap with them, so they get used for various things, where they kind of broaden over into the different categories. This wheel we're going to get really familiar with because we're going to break it down. But it's essentially divides those categories out into seven different categories: and stimulants, cannabinoids, and pathogens, opioids, depressants, dissociative drugs, and then psychedelics. But before we get too far, let's talk about a little assessment. Always remember A, B's, and C's. So airway, breathing, circulation with any of those. Get a good sample history on your patients. That's going to tell you a lot about them. One of the things in working in the ER that I was taught at very, very soon is one of the physicians used to always tell me that if you listen to your patient long enough, they'll tell you exactly what's wrong with them. That's always been kind of a good guiding factor. If they can talk to you, they're going to tell you what they took eventually if you keep them talking to you. But some specific questions you can ask are: what drugs, when did they took them, how many did they take, and how were they taken? Because there's all various kinds of ways to take them. And then how long that they've taken will tell you how onset and half-life and those things that we learned back in pharmacology. Like I said, we're going to talk about this graph as a whole. Break it down just to cannabinoids. These are some different names for them. Specifically, I don't know that I've heard of many other these besides Mary Jane when you talk about cannabinoids. We see this a lot with the THCs and the cannabis being medically legal. We've seen just a huge uptick in that over time. It comes in different forms. They're going to be cannabis. They're going to be the medical grade cannabis. There's going to be oils. There's going to be the CBD oils. And there's going to be synthetics. You're going to have different effects. Anything from euphoria, feelings of well-being. Sometimes it gives them a false sense of security. Some spontaneous laughter, increased appetite, dry mouth, quiet and reflective mood, paranoia. These are what we would classify kind of in normal lingo as their stone people. They can be, they're used either smoked, vaporized, or eaten. Pharmaceutical wise, they can be raw, vaporized oils, eaten, gels, liquids, oral sprays. They're making them just about every form that you can get. And they are pretty prevalent. I mean, you've got the cannabis shops that have popped up all over the place. A lot of times with cannabinoids, they're going to be using other things, and then they may refer to them as some street lingo. Look at atom bombs, they're marijuana and heroin. Gimme is marijuana and crack. My one, when I'm looking at this, that I would be most concerned with is some ozone, which is marijuana, crack, and PCP. They're going to have a huge kind of internal struggle going on within their body. Care for these folks would be supportive and crystalloids, benzos, antiemetics, and you might even have to consider some restraints depending on what they've got involved with. One of the things to remember with these, and one of the reasons the antiemetics is big, is cannabinoids in general will cause them to get a hyperemesis syndrome, much like you would see in a pregnant woman with hyperemesis gravidarum. So they're going to be most likely going to need some kind of antiemetic on board. The other thing with cannabis that you got to look at as well is that it makes them more susceptible to having a seizure as well, amongst some other medical conditions that can cause. Moving on, looking at just stimulants in general. They've got some different names with those. It's going to include things like cocaine, crystal meth, and amphetamines. Crank is probably one of the more common street names for it. Some of the other ones, I don't know that I've necessarily heard much, if ever. It comes in different forms. Caffeine is a stimulant. All of us use it. Nicotine is a stimulant. Some of us use that quite a bit as well. There's illegal stimulants. There's prescription stimulants like Adderall. I don't know the exact number off the top of my head, but Adderall at one time was the most commonly abused and passed around drug on college campuses because it would get you to focus. And we do have a college here in town, so something to be leery of. Effects, you're going to need some euphoria with it, heightened feelings, increased alertness or focus, and talkativeness, increased heart rate, blood pressure, reduced appetite. In the higher doses, you're going to get seizures, increased temperature, nausea, and even coma. They're snorted, swallowed, smoked, and injected, so in various forms. Effects with other drugs. A lot of times you're going to see some amphetamines and some antidepressants. You'll see amphetamines with alcohol, cannabis, or benzos. See ice with alcohol, benzos, and ice with speed or ecstasy. I find it interesting when you start talking about stimulants and you start putting them with alcohol, which is a depressant. Those people, I think, are just having a huge internal war going on inside themselves. When you look at the treatment for them, they're going to be aggressive supportive care. Restraints will sometimes be something that you need to do either chemically or physically. Assess and treat any arrhythmias depending on how high the ingestion they actually took. Same way with the securing the airway, depending on how much that they took. And then seizures is definitely going to be something that you're going to see, and you need to be prophylactic with it and really watch for those as best you can. Complications specifically with stimulants, hyperthermia is a big deal. In the pre-hospital world, we don't see it a ton, just because we don't take temperatures on the regular. But you do see it once you get them in the ER and the ICU. These patients, as the drugs course through their body, will become hyperthermic. They're going to be on cooling blankets and pack them in ice and things of that nature. A lot of times you're going to get liver failure just because these are going to be metabolized through the liver. A lot of them are paired with alcohol, so they're going to have some damage to the liver if they're full-blown alcoholics and have been doing that for a while. Rhabdo, because with the stimulants you get increased movement, so they're having a lot of muscle breakdown with the rhabdomyolysis. And with the rhabdo, you're going to see kidney damage and really some liver failure as well, as the body tries to get that excessive myoglobin out from the muscle breakdown. So you're going to need to use fluids as well to flush them out. When we look at depressants, these really encompass a lot. Depressants as a whole are going to kind of slow people down. They're going to reduce any kind of stimulation, and then they're going to enhance the action of the neurotransmitter GAMA. So it's going to slow their central nervous system down. I'm looking at different depressants. Probably the ones I see, the street lingo I see the most is probably bars, when they talk more about like Xan bars and things like that. I don't know that I've ever seen any of the other. I definitely have never heard someone refer to it as Georgia Homeboy before, but I guess it is out there. Different forms, like I talked about with alcohol. Alcohol is a depressant, so we see that benzos are pretty prevalent amongst street use. GHB, propanol, barbiturates. Barbiturates aren't so much prevalent as much anymore, just because there's just not that many that are prescribed so much anymore. They use other things. But I can remember when I first got in medicine, barbiturates were pretty prevalent. Um, the effects, they're going to be reducing inhibitions, reduced anxiety, and impaired judgment. Have some slow reaction time. A lot of times these people vomit, and they vomit a lot. If they take enough of things, then they're going to have a depressed respirations. People that aren't breathing well, that are throwing up, we tend to secure their airway, so that's definitely going to be something. A lot of times these, if you look at just what we give them for on a medical basis, they're going to have those same kind of side effects with it, memory loss and loss of consciousness. So when we give benzos, we're typically giving them to sedate them, and that's really what they're doing. They're used, they drink them, get drunk, they inject them, they snort them, they inhale them, they swallow them, and they can cause a lot of problems. And sometimes they do multiple different types of delivery methods. When you look at depressants as far as treating, and with their other drugs, you see alcohol and benzos quite a bit. So you got two depressants on board. You can see benzothiazines and opiates as well. We're going to look at treating with some flumazenil or romazicon to try and reverse those agents. It's supportive care, airway, breathing, circulation, or you can't stress that enough. Potential antidote with romazicon. If they're somebody that uses routinely and in a large quantity, we've got to look for symptoms of withdrawal. So treating seizures, which is, I would tell you to be cautious if you've got somebody that's addicted to benzos, giving them a big slug of romazicon just because of the seizure component of things. If you give them romazicon and they're on benzos, you got to worry about the anxiety. You want to monitor heart rate, blood pressure, and temperature, and then some kind of restraint. A lot of these, when they're on depressants and they've overdosed on those, typically what we're going to do is we're going to end up securing that airway. These are the patients in the ER that we secure the airway, and then we send them in the ICU, and they kind of sleep off what they're on, and gives us a good handle to treat the withdrawal type symptoms. Dissociatives, we willfully give some of this. When you look at ketamine, ketamine is getting used and prescribed quite a bit. In previous lecture, I talked about PTSD. I actually saw ketamine is getting used orally for that. And so with that, it's now available on the street. I don't know that I've ever seen anybody use nitrous oxide, but it is out there. And methoxantamine, I don't know that I've ever seen in this area. So it comes in different forms. Ketamine, PCP is in with the dissociatives. Dextromethorphan is one that's interesting to me because you can find that in just simple cough syrup, which carries its own problems. So if you have someone drinking bottles and bottles of cough syrup that have dextromethorphan, they could get some dissociative properties with it. The MXE and the nitrous oxide we talked about. The effects of those, they're going to be in a trance-like state. If you've ever given ketamine on the truck or in the ER or in practice, we talk about putting them in the K-hole. That's what you need to kind of envision. They're going to have amnesia to it. It does provide some analgesia, and so they typically don't complain of any kind of pain. They have a sense of floating. They have disordered perceptions. I did use ketamine professionally on a patient a couple weeks ago with a pretty severe broken leg to kind of reduce that in the field. We end up just giving him ketamine while we were taking him to the hospital as well, because it does provide some amnesia and some analgesia and puts them in the K-hole, so they don't really know what's going on with broken bones. But the problem with it is he got to the bad trip of being disassociative, so we had to use some other things. So it is something that can get to that bad area as well when we get them, when we get in high levels. They're used, like I talked about with syrups and the dextromethorphan. There's sprays, there's tablets, there's lozenges. I mean, they're snorted. You got injections of it, inhaled. Anytime you can IM inject it, then you got people that will try and inject it into their veins as well. clicker die? No. Okay. When we look at ketamine continuum in general, we look at the left side of that. That talks about different dosing parameters, depending on what the effect that you want to get. And so, depending on how much they're taking, is where they're at on it. It goes from 0.1 milligrams per kilogram all the way up to greater than 0.7 milligrams per kilogram if you want to be completely dissociative. The analgesia dose does work well, and then all those doses work well if you know what you're doing. But the problem is when people get them on the street, they don't really look at that, nor do they know what they're doing. When we have somebody that's on a dissociative, we want to give them supportive care, and sometimes restraints comes in there. And when they come out of it, you got to remember that when they come out of it, they're going to be doing exactly what they did when they went into it. I can tell you from an ER nurse perspective, and when I first started flying and we started using ketamine quite a bit, I was pretty leery of it because in the ER, the only time we ever gave ketamine was to give an IM injection to a kid that we were about ready to sew up. And those kids are like little raging hyenas because they're worked up because they got an injury going on, and then you come at them to give them a shot. And they go into that dissociative disorder, but man, when they wake up, they come back and do the same thing because in them, they're still kind of doing that. So it's something to remember is once you start giving it, to make sure you give it until the right time to bring them out of that dissociative property. One of the interesting complications with ketamine is a ketamine bladder syndrome. That's where they can take regular large doses of the drug, and with the bladder, they have difficulty actually holding their urine and they become incontinent. It requires care by a specialist of a couple different specialists, both urology and making sure that we can clear the drug out. But it's something to watch for when you get, especially those younger folks that don't have a necessary injury that causes some incontinence. Definitely something to look at. Dissociatives can cause a B12 deficiency as well as anemia as well. In pathogens, when we look at these, there's some different names for them. Molly is probably the one that I've heard the most over my career, and typically it's referring to MDMA, which is by far the most common one. When we look at different forms, it's MDMA and ephedrone. They have a sense of belonging or connection is the biggest effect from it. They're typically going to be sexually aroused, so they're going to be very friendly to you. They're going to have a lot of energy. They can complain about being real hot. But for the males, they'll be sexually aroused, but they'll also have erectile dysfunction, and then they're also going to be dehydrated. These can be used in very different forms, swallowed, pill or capsule. They can shove it up their hind end and give it to themselves rectally, snorted in a crystal form. For those that don't know what MDA is, ecstasy is kind of the name that goes around for it. Ecstasy can include MDMA. Is where you're going to see MDMA quite a bit. Looking at psychedelics, it's going to. I skipped a slide. I did skip a slide. There we go. When we look at empathogens, and then we'll move on to psychedelics. We got to look at what people are taking when they take these as well. SSRIs is a form of psychiatric drug that is a class of drug that is prescribed pretty prevalently, and they get a hold of empathogens, and they can put them in a serotonin syndrome, which is a big emergency. They're going to be confused, anxious, agitated. lots of increased heart rate, sweating, muscle spasms, and serotonin syndrome can actually be very fatal. So it's good to know if they've been using MDMA, if they're also using SSRIs. Unfortunately, these patients that typically use a lot of illicit drugs are going to carry some kind of psychiatric diagnosis as well. Um, and so you have to kind of make sure that if they've been taking their normal psychiatric medicine plus their street drugs, it's a big deal. They also see antidepressants, tryptophan with that, but they do have some things with it. The biggest thing is they're going to cause is some hyperthermia. Um, Treatment wise, you're going to consider some restraints. Electrolyte imbalances are big, especially late or later after the ingestion. They're going to have a big shift in their electrolytes. Keep them in the hospital. Hyperthermia is huge on them because they're moving and their body is kind of an overdrive. You want to monitor for any kind of complications. Complications would be like renal failure, seizures. They're going to be dependent on it or have a huge tolerance to it, which could lead to overdose. Now, psychedelics. These are going to have different names to it. Acid and shrooms are by far the two biggest names that I've seen in our area. When we look at psychedelics, there's definitely different forms, like with everything else. LSD is a big one. That's probably the most common. The one that starts with a P, but I don't pronounce it very well. Psilocybin. That's what comes from fungus and from shrooms. Mescaline, you don't see a whole lot. It's from that peyote or peyote. Sorry, my like I said, I'm a little tired right now, so peyote's there. We see it a little bit around here with the Native American tribes and those things. DMT and DOM, we don't see quite so much. I didn't know this, even though I pronounced it wrong, but peyote actually comes from a cactus, and that's the most potent form of it. I did not know that. Effects, you can have some euphoria, relaxation, some hallucinations. Blurred vision is common, clumsiness, tachycardia, numbness, and some vomiting. They're used, spoke, swallowed, inhaled. Brewed in tea is interesting to me because you will see some of that. I mean, that's just something you have to pay attention to and look for. Cooked or snorted is another way that they get those. Effects with other things like stimulants, alcohol, and other drugs, they're all going to go hand in hand. Bad trips are probably the biggest thing that you're going to see, and they typically will cause some panic and unpredictable behavior, and they can lead to just getting yourself into an accident, like running across the road because you're not aware that there's cars going across the road, and or you can not be aware of your surroundings. So they can have the bad trip. You want to consider restraints with them. Treat the nausea, treat the vomiting, treat hyperthermia if you notice it, especially in the field. As we're getting into kind of the cold time of year, that's a little harder in the field to get a hold on, but it is definitely something to pay attention to. Above all else, support the ABCs and monitor and treat for any common complications. Like I talked about with the bad trips are big. If you combine these with they're carrying a diagnosis of something like PTSD, they could have flashbacks, which could further complicate things for you. They're going to somewhat develop a tolerance to them, and then seizures are a possibility as well. Treatment could range to taking their airway from them and controlling them and giving them, because you'll have to give something to control seizures as well. If persistent, they're in that more psychedelic phase, you can have a persistent psychosis with it. and it can include some pretty severe visual disturbances, very disorganized thinking, paranoia, mood changes, and everything that comes with those. They are very prone to violence as well when they're on that bad trip. So be leery and wise to that. The next one we're going to talk about is opioids, is by far the most prevalent. In talking and looking at various names, I don't know that I've ever heard very many of these. I've heard smack before, but I've never heard China White Kickers, Monkey Dragon, Captain Cody. I would remember if someone called it that, but I don't know that I've ever. I mean, if you want to put in the chat what you've heard them before, these are not all of them. I don't know. I would love to. I mean, that might be a good side gig for somebody coming up with some of these names. So, yeah, opioids, we see quite a bit in this area. They can be in different forms, different names. This is not exhaustive by any means, but the most common one are heroin, oxycodone, Percocet, fentanyl. We're going to talk about fentanyl because it's a big riser right now. And multiple prescription medicines can cause that have opioids in those. A lot of times they're combination drugs like the Percocet and the oxycodone. You're going to see them with some Tylenol in them as well, so it further complicates how you manage these patients. Effects: extreme relaxation, respiratory depression are the biggest and the most prevalent. They're going to have some confusion, slurred speech, constipation. Little fun known fact: constipation is actually what killed Elvis from an opioid overdose. He had a heart attack sitting on the toilet trying to push out something. Increased tolerance and analgesia. These people you're typically not going to have to give much pain medicine to. They use them very different ways: swallowed, smoked, injected, snorted. I've even seen people stick them up their hind end before too. If they're opioid addicted, they do some strange things with them. I've seen people try and smoke fentanyl patches before, which is highly deadly. I've seen them try to chew the patches. It's opioids is a big problem. Opioids, and we're gonna spend a lot of time with fentanyl because it's the most prevalent and coming up right now, and is really kind of one of the most dangerous drugs. But they combine fentanyl with methamphetamine, heroin, cocaine. A lot of times they give unknown doses of it. Interesting study that is in here is that my notes that when the DEA analyzed street pills, they found them from a concentration ranging from 0.2 to 5.1 milligrams, not micrograms, more than twice the lethal dose of a fentanyl per tablet. I mean, that's a ton of fentanyl. 42% of the pills tested contain at least 2 milligrams. That's 200 micrograms. That's a lot. It's just a lot. Consider a lethal dose. A kilogram of fentanyl has been estimated that it could kill up to 500,000 people. It's huge. The good thing is we've gotten Narcan available to most law enforcement, so that's a good thing, other than naloxone. Treatment for this is going to be supportive, especially the respiratory. Narcan, be aware of withdrawal. Complications can be the Narcan or naloxone half-life and polydrug use. I mean, typically when the people use fentanyl, they're using more than one drug, like it goes with most illicit drug use. They've got a lot of polypharmacy going on. Gray death, if you haven't heard of it, it's a very potent opioid. It's a combination, can be lethal in small doses due to the potency of the opioids. A lot of times it has a lot of fentanyl in it. Some of the myths about it is just touching it can kill you. It should be with a little asterisk. I mean, it depends on how much of it you're touching and how you're handling it. What I would tell you is to be cautious with handling any type of drug, especially what you don't know it is. It's just like bodily fluids. You don't know if it's not yours. don't touch it. Make sure you got gloves on when you're around it. Um, you need some kind of respiratory support to be in the same room with it. It's a myth as well. It depends on what the concentration is. Obviously, exercising caution. The truth about it, it often contains carfentanil, which is very, very, very potent and can be deadly. It also has a lot of other combinations of opioids, and it looks gray. And then if I haven't said enough, it can be lethal for you. So be very cognizant of it. If you've got people with the dust on them or that nature, just be leery of it. Unfortunately, we're at the place in our society we have to. Other types of drug use, they mix drugs and call it things like sextasy or trail mix. And you can have serotonin syndrome with it as well. There are inhalants, huffing and sniffing. If you're old enough, I remember this commercial that says, "This is your brain on drugs with the egg fried in the frying pan." Any questions? As I get older, there are more and more people like Madison Smith that have probably never seen that before. Ask one of the people with gray hair. They're going to tell you lots of stories. Xylazine is a new one for me. I don't know how many have heard that name. It's commonly called Trank. It's a newest drug that kind of hit the illicit drug abuse market. It's a non-opioid sedative, analgesic, and muscle relaxant, so it covers all things. And it's intended for use and widely administered among veterinarians, especially in horses. So some of our horse people probably have heard of that. Horses scare me, so I kind of stay away from them. But so that's probably why I don't know about it. It is a controlled substance in the United States. It's quite not currently a controlled substance in the United States. So it's easily and available domestically and online. It's incredibly cheap. It ranges from about $6 to $20 a kilo. So it makes it appealing to those people trying to turn a profit on the illicit drug market. It's rapidly spreading. One of my friends helped write this lecture, and she lives out in California, and she said that she has seen this before out in that area, so it's kind of sweeping across the United States. Ironically, when I was talking to her, she sees this, but methamphetamine is kind of new to them out in the California area, and we know about it quite well. It's marketed for, like I said, use for animals, so be leery of it. This is a good chart when you start looking at numbers by region. We look at the Midwest. When they started testing those in 2020, just in a year, and it's older data, but I think it shows us it's definitely on the rise. 2020 had 57 cases of it. 2021 you had 351 cases of it just in the Midwest. That's a 516% increase. I mean, you look at the South, which it being among horses and veterinarians and whatnot, I mean, that's the biggest jumper. I think of horses, I think of people in the South. So other types of drug use, they're going to be combined, xylazine or by itself. Fentanyl and xylazine together is a pretty potent combination. It can be very lethal. Heroin and xylazine as well, and then xylazine alone is something to definitely watch for. It affects, you're going to have some dry mouth, drowsiness, hypertension, and tachycardia with it. You also get some rebounding effects with it. So if the things on the left weren't enough, then they progress on to, you're going to see some hypotension, bradycardia, hyperglycemia, hypothermia, coma, respiratory depression, dysrhythmia. Depends on where you catch them at as far as when they've ingested it. When you look at treatment, we're going to support care and ABCs. Wound care is a big thing. It can be interesting because it causes these wounds regardless of how they're ingesting it or how they're using it. Um, I equated a little bit in looking at it when we started talking about back in the 60s and 70s, and people kind of had that drug itch or the methamphetamine spots or things like that. It carries its own set of skin complications with it as well. We're going to be supportive and talk about the ABCs. The interesting thing about it is that Narcan is not effective to it. If it's combined with something like a fentanyl, then Narcan will take care of that portion of it, but xylazine of itself, Narcan does not work. A lot of times you're going to see the skin stuff where they're going to need to get taken care of with some antibiotics and put in the hospital for that as well. You have instances of sepsis with it and pretty bad skin infections that come with it with these significant skin lesions. So in summary, illicit drug use continues to rise, as does death from use. Drugs can be divided into 7 different groups. Assessment focuses on specific drug used. Treatment is generally supportive. Restraints are often prudent, whether or not the patient is combative. It's just to keep you safe. And with that, we'll open it up for questions, and I'll put up a QR code here. It's been a year or so. You've seen that one they were having up there in Philly, it's like a zombie drug, some sort. That one? I have. I can't remember what it's called though. To me, there's so many designer drugs that are coming out that. Does it? Am I muted? No.
All right, since we don't have any questions for Nate, we will see you back here at 1 o'clock for Kaylee Dorsey. She's from Mercy. She's going to talk about CHF. So we will see you at 1.